Kim, before you give Amy's official bio, I just wanted to welcome everybody and just to say I am personally and professionally thrilled to have Dr. Amy Walters presenting for us today for our monthly ABIN webinar. We've been really blessed to have some excellent speakers because it's our chance to pick people that we know we like and that are excellent in the field. So we've had some great speakers, and Dr. Walters is definitely up there in top speakers, and somebody that we decided a few months ago that we really wanted to get somebody to speak on about integrated behavioral health, and specifically addressing issues related to chronic disease. And Amy is someone I've known for a few years, maybe since 2017 or 18. And she's somebody that definitely walks the walk and doesn't just talk the talk. She's a psychologist that's very up to date on the evidence base and teaches and is a consultant, but also she's working day to day. She's in her office today and we'll be doing this type of work. And the other thing is, over these years, anytime I've needed anything, I may contact Amy and say, hey, do you have an article about this? Or what do you do about that? Or so I just personally want to thank Amy and just let y'all know that you're in for a treat to be able to hear Dr. Amy Walters today.
Thank you so much. That was very gracious of you, Patty. Happy to be here.
Absolutely. Well, I'm going to read your official bio, Amy, if that's all right, just to set the stage for you, so people get a better understanding of your background, experience, and what you do. And so, as Dr. Gibson said, this is Dr. Amy Walters, and she is a clinical and health psychologist and a clinical consultant for Cornerstone Whole Health Organization. Dr. Walters is also the Director of Behavioral Health Services for St. Luke's Humphreys Diabetes Center in Boise, Idaho. She works with patients to address emotional and behavioral factors which negatively impact in chronic disease management. She provides professional presentations on behavioral health integration, motivational interviewing, and psychological factors impacting chronic disease. She received her PhD from Utah State University and has more than 20 years of experience working in clinical and community settings with both adult and pediatric populations. She is a longstanding board member of the Idaho Psychological Association and serves as the APA Public Education Campaign Coordinator for Idaho. Dr. Walters also volunteers as the staff psychologist for the Idaho Diabetes Youth Programs and also has a daughter with type 1 diabetes. And I just wanted to give you a warm welcome from Arkansas. We, as Dr. Gibson said, we have been working with Dr. Walters for the past few years, and we've had an opportunity to hear her speak and really know how knowledgeable she is in this area. So we are so excited for you to share this information with Arkansas and all of the people on the call today. With that, I'll turn it over to you, Dr. Walters.
Thank you so much. I'm really happy to be here today, and I really appreciate the invitation to meet with your group. I feel very passionate about supporting patients with diabetes and other chronic conditions, and just want to share kind of an overview for you today, talking a little bit about, so we'll go on to kind of our objectives, talking just a little bit about what some of the psychosocial factors are that impact diabetes, and then try to build some understanding of just the importance for supporting those behavior change goals. BHCs in integrated settings are in such a fantastic position to be able to provide that support to the rest of the team, because this is often kind of an unsupported treatment recommendation. And then we're just going to learn some practical strategies to try to kind of help enhance health behavior and cope more effectively with diabetes. So thank you so much for having me today, and excited to be here. So I always like to level set with just talking a little bit about, what is diabetes? Sometimes behavioral health providers have a background and sometimes they don't. So having a little bit better understanding about the condition. In general, it's a disease of insulin production and use. The body stops making insulin or can't make enough. Cells become resistant to insulin, and insulin is a hormone that allows us to use the glucose that we consume as fuel for our cells. There are two types of diabetes that you'll hear about most often. Type 1 diabetes, which historically has been referred to as juvenile diabetes, which is an autoimmune condition, and type 2 diabetes, which is actually a metabolic condition. In general, insulin is required for cells to use that glucose as fuel. And what happens with diabetes is the blood glucose levels become too high, start to cause damage to various systems. Unmanaged diabetes leads to serious health complications, and many of you have probably heard about those. But these are things like vascular disease, both micro and macro, nerve disease, kidney disease, eye disease, and so on. So some pretty serious complications if we're not addressing those. Talking just a little bit more about type 1 diabetes. So this is an autoimmune condition. Typically, people have some kind of genetic predisposition, and then there's an environmental trigger that kind of kicks off the disease. Oftentimes, this is diagnosed in childhood, but we can see type 1 diabetes at any age. And we do see diagnosis in adults and adolescents as well. One of the things to understand about type 1 diabetes is that people are insulin dependent from the onset of diagnosis, and it's life-threatening if they don't get insulin pretty quickly. Their body goes into ketoacidosis, which can lead to coma and death. So insulin delivery becomes part of daily life for people with type 1 diabetes from the onset of diagnosis, and this is delivered either through a syringe, through an insulin pen, or through a pump. Type 1 diabetes requires this rigorous daily management of their medical regimen, and this is going on for a lifetime. People need to be checking their glucose levels regularly, typically at least 4 to 6 times per day, and then taking insulin based upon those numbers. They also need to really clearly monitor their food intake and check carbohydrates. So with each meal, they're going through a pretty extensive process to count the carbohydrates that they're having. They're calculating their insulin based on that, and then dosing it accordingly. There's also this balance that goes on between managing their high blood sugars and trying to keep those under control, but also preventing low blood sugars, which also have serious health complications. So people with type 1 diabetes are always in this balancing act of trying to stay in the kind of this sweet spot with their blood sugars and have concerns about ongoing hyper and hypoglycemia. Type 2 diabetes is actually a pretty different condition. As I mentioned, type 1 is autoimmune. Type 2 is actually a metabolic condition that has a very strong genetic component, and obesity is a risk factor, and we hear about that a lot. But we don't want to underestimate the genetic loading for type 2 diabetes. Many patients with type 2 diabetes will talk about the guilt and shame they experience because of difficulty in making lifestyle change, but reminding our patients that there is a really strong genetic element to this as well. Within type 2 diabetes, the cells become insulin resistant. And so the pancreas is starting to work overtime to really produce that insulin. And as this is occurring, glucose starts building up in the bloodstream. One of the challenges of type 2 diabetes is that people are often asymptomatic until they're at an advanced stage. So you'll sometimes hear this referred to as like a silent killer. And people can have pretty extensive nerve and cardiovascular damage before diagnosis if they haven't been regularly monitored. Treatment for type 2 diabetes is a combination of medications. Typically, they'll start with an initial agent, like an oral agent like metformin, and then build to additional agents if they're not able to control glucose levels. So moving from that monotherapy to kind of a dual therapy and so on. And there's a big emphasis on weight management as an important part of managing type 2 diabetes. This creates a challenge because as we're having more issues with insulin resistance, it becomes harder to lose weight. So treatment for both conditions is this daily balancing act of managing their diet and their carbohydrate intake, taking their proper medications, and then making sure that they're getting enough physical activity. So having just a basic understanding of treatment as a BHC is really helpful because that gives us a sense of the condition as well as how we might be able to intervene. So thinking about just the basics, and this is going to vary a little bit based on the individual, but having a basic understanding of what dietary change looks like. Typically, we're looking at a reduced carbohydrate diet and following a heart healthy diet because of the cardiovascular complications. Typically, we see people trying to shoot for this range of about 45 grams of carbohydrate per meal for maintenance, and less than that if they're trying to do weight loss, often 30 grams per meal. I don't know if you've ever counted your carbohydrates, but this is a great little exercise for BHCs to go through to understand what we're really talking about here. So, for example, if you take kind of a traditional American fast food meal, a piece of bread has about 20 grams of carbohydrates. So if somebody even has for lunch, say a sandwich, I think you get a pretty healthy meal, like I'm gonna have a sandwich, I'm gonna have an apple, and then maybe I have a small bag of chips. You're looking at about 40 grams of carbohydrate for your sandwich, you're looking at about 20 for your apple, and then you're looking at about another 15 to 20 for your chips. So just in a standard meal like that, somebody's already over their carbohydrate recommended intake. So just thinking about how challenging this can be for patients and being able to provide some understanding and support in that area. We also need to be working on physical activity. That's a really important element of being able to reduce insulin resistance, help bringing glucose levels down, and making our body more receptive to the insulin that we do have. So the general recommendation for patients is that they're getting activity about 150 minutes per week cumulative, and 30 minutes over about 5 days per week. One factor that's important for people to recognize is this doesn't have to be 30 minutes straight. It's definitely a cumulative effect. So any kind of physical activity can help build, and we want people to get to that 30 minutes per day mark. And then we have that medication piece. So with our type 1 patients, we're working on our insulin and making sure that they're adherent with that regimen. And type 2 patients, we're working on making sure they're consistent with their oral medications or any others that they might be on. And just to kind of pause there for a minute, happy to take questions as we go along. Kim, if you don't mind monitoring the chat for me, and if something comes up, just letting me know.
Absolutely. Thank you, Amy. And please unmute yourselves and ask questions or put them in the chat. We would love to answer them as we go along.
Absolutely. And we'll definitely take some time at the end as well. So just thinking about the things that we've talked about so far, try to imagine in your own mind, if you were living with diabetes, or maybe you know someone who has diabetes, what kinds of things might come up in terms of a daily basis and some of the psychosocial factors that would impact it. So just thinking about that for a minute as we move on to this next phase. I'd like to talk a little bit about areas of impact of chronic disease. When we think about chronic health conditions, and this applies for diabetes as well as other things, we tend to think about just the physical health condition. And while, yes, that's at the center of our focus, there are all these other areas of impact that people with diabetes struggle with. And so just thinking about those and having an awareness that there's opportunities to intervene, to first assess how things are going in each of these areas, and then intervene to provide support. One of the things that we see is that chronic disease is definitely has an impact on the entire family. When we think about for patients with diabetes, especially for our pediatric population, families are having to really shift to be able to accommodate this really intense medical regimen. They're working on lifestyle change, trying to get more active, and also changing eating habits. We know that food is a really important part of family culture. And so this can create some challenges and barriers when it comes to diabetes management, just looking at that ripple effect that it has on the family. There's a financial impact to diabetes. It's a very expensive condition to manage, especially when we're talking about our pediatric patients and our type 1 patients. We often have not only insulin costs, and there's been a lot of information in the news recently about insulin costs, but also testing supplies for monitoring glucose levels. If they have any of the technology like continuous glucose monitoring or insulin pump, all of these things are very expensive. Have run into multiple patients in our setting who are feeling the strain financially and feeling like they have to choose sometimes between paying for their diabetes supplies and paying for other bills or addressing other areas in their life. So this is a really important area for BHCs to assess. In one of our rural clinics, we had an individual we were working with, really, proud farmer who didn't disclose this initially, but after meeting with one of our BHCs, had an opportunity to kind of talk through. And what we found out was he was actually administering his insulin and taking his medications only every other day, which was ending him up in the ER on a regular basis. We were able to kind of identify that factor, get some supports in place with some of our programs through our pharmaceutical companies. And then once he was able to take his medications more consistently, we saw a huge drop in ER utilization. So great area to really be aware of and assessing. People will talk about a career impact with their diabetes due to the demands of monitoring, also worrying about kind of high blood sugars versus low blood sugars. In some roles, people may not feel like they have the time to take breaks regularly to check. There could also be kind of risk factors if they're having low blood sugar. So one of the individuals that I worked with over time was a roofer. And so he was really concerned about having a low blood sugar, which would cause dizziness. It could be, potentially risky. So he would intentionally allow his blood sugar to run higher as it just the fear of hypoglycemia. So recognizing what the impact might be when it comes to work life. There can be a mental impact to diabetes. As blood sugars are varying, we see changes in cognition, so issues with attention, concentration, and memory, and this can have a negative impact, especially for some of our students in our college population, something we want to be aware of and helping them address. Also looking for potential like 504 accommodations in those school environments to address some of these challenges. There's also an emotional impact to diabetes. We definitely see higher rates of depression and anxiety in this population. In addition, people will talk about a lot of guilt and shame as challenges with managing blood sugars arise. So having an awareness of that and being prepared to support those areas. And then finally, there's a social impact. As I mentioned, anytime we're working on lifestyle change and dietary habits, this food is very social. And so people will talk about, one of the things that I do for fun is I go out and eat with my friends, or I do beer and pizza with buddies after work. And so how am I supposed to manage that with my diabetes? So looking at all of these factors and being able to address them and support them in the BHC role. We also want to think about kind of health in context anytime we talk about chronic disease. So definitely focused on this individual and their life and the factors, but that individual is embedded in a family. And as I was discussing, there's kind of this bi-directional relationship where the disease impacts the family and the family impacts the disease. So having an awareness of those factors and how they may be impacting disease management. We also see community and cultural factors. So thinking about the disease in context and how these different elements may be impacting the individual. So when we think about just kind of psychosocial impact overall, one of the things that I always like to bring up is there's a lot of grief and loss that goes with chronic disease. People have a sense of loss over their good health, over the life they were hoping to have, and over just dealing with the demands. So having an awareness of those factors and being able to talk through that can really be helpful. We hear a lot of discussion about, as I mentioned, kind of this guilt, this hopelessness and helplessness around their condition. Sometimes people feel very socially isolated, and they feel frustrated when they're working really hard to try to manage their diabetes, and yet the glucose levels are all over the map. This can build some kind of feelings of learned helplessness, which can then reduce that feeling of efficacy and reduce their engagement in their diabetes management. Oftentimes people feel like diabetes kind of rules their lives and defines them as an individual, and they can just struggle to be able to balance the demands of daily life, family life, career life with the demands of their disease. As I mentioned, we also see higher rates of depression and anxiety in our diabetes population. Depending on the study, this varies anywhere from kind of 30 to 50%, so much higher than we typically see, so something that we want to be watching and addressing. When we do have co-occurring diabetes and mental health issues, this increases our risk factors and also increases costs of treatment. What we tend to see in the literature is a report of lower quality of life, poorer treatment adherence, poorer glycemic control, and increased rates of ER utilization and hospitalization. We do see higher rates of diabetes among our patients with serious mental illness. 60% increased risk for diabetes among patients with depression, and a 2 to 4 times higher risk among patients with schizophrenia. We also see there are a number of different psychotropic medications that can increase issues with weight and insulin resistance. So having an awareness of those, I have a few listed here for you. And sometimes working with our providers if they are on an agent that's creating more issues with weight gain and insulin resistance, and being able to look for alternatives. So it's definitely important in this population that we're doing regular screening. Here in our clinic, we typically use some of the common rating scales for depression, anxiety, PHQ-9, GAD-7. We use an SBIRT to screen for substance use. And then there's another scale called the PAID, which is one out of the Joslin Diabetes Center that looks at diabetes distress. And this can be a helpful tool when patients are really struggling and we're not always sure which areas, which identifies, it's about a 20-item scale that allows us to kind of look at different areas within diabetes management that we can help target in our interventions. And we definitely do these at initial appointment and then annually or anytime we have additional concerns. In the end, managing diabetes successfully is all about change. So making those changes in behavior to support lifestyle, being able to deal with the changing emotions that can come with diabetes, and then addressing some of the changes in thinking that we need to have about health, about eating habits, about managing condition. I feel like supporting behavior change is kind of the elephant in the room. It's required to meet all the other treatment goals that we have when it comes to diet and exercise and medical regimen. It's important for healthy coping, and yet it's often unsupported for our patients. So what we tend to see then is this phenomenon where patients will come in and they say, I know what I'm supposed to do, I just can't do it. And that causes a lot of frustration. They feel like a failure, and we fall into this pattern of learned helplessness where they may give up and just say, like, forget it. I'm just going to go for the chocolate. I'm going to eat what I want. I'll lay on the couch and watch TV. What's the point? I can't do this. It's too hard. So adherence becomes a significant challenge within this patient population. And I like to talk about adherence because in the medical world, we have great information. We want to support our patients. We often hear providers talk about how frustrated they are that patients are not being consistent and feeling like it's a surprise. And yet when we look at the research on adherence, most chronic conditions have adherence rates that are actually quite low, oftentimes below 50%. So thinking about that, we actually know that the majority of our patients are going to be non-adherent, and that this really is the norm and not the exception. We also know that self-report for adherence tends to have poor accuracy across conditions. So what people tend to do is they over-report their success and they under-report the issues. As providers, this is frustrating. We may say, gosh, I don't know why my patient's being dishonest. So we may be having a conversation and the patient's saying, oh yeah, things have been going really well. I'm doing great with my diabetes management. And then we download their CGM or we download their meter to look at the numbers, and they're actually quite different than that. So really encouraging people to get the data, making sure that we are looking at that, but not assume that the individual is lying, that this is just kind of human nature for us to over-report what we do well and under-report what we struggle with. We also see a decline in pediatric adherence with progression in age. So when kids are younger, parents are typically very involved in their diabetes management. We see better adherence. And yet once we move into adolescence, that tends to be a struggle. So understanding good adherence is one of the roles that you can play as a BHC. We're really talking to the team about this and working with patients, that this is a really common phenomenon. And if we can follow kind of this 80-20 rule, where 80% of the time we're on track with our recommendations, then people tend to do pretty well. So setting kind of more realistic expectations around adherence. There are a number of different factors which impact adherence. One is self-efficacy, so just how confident the individual feels with their ability to care for themselves. We also see that initial adherence is a pretty good predictor of longer-term adherence. So people who do well right out of the chutes tend to have better adherence over time versus those who struggle. And definitely, if there's been an interruption, things like schedule changes, vacations, changes to work routine, all of those things can have a negative impact on adherence. So working with patients about being able to anticipate and plan for that and recognizing that those may be challenges. We also see lower rates of adherence among multi-behavior regimens. So diabetes definitely falls into that category where we're working on, testing glucose levels, administering medication based upon that, changing eating habits, all of those things. When we look at the reasons that people struggle, number one is they really do forget. And oftentimes this just seems counterintuitive. Like, how can you forget? This is something that you do every single day. And yet patients talk about falling into this pattern of kind of Groundhog Day, where it's like, I swear I just did that, because they did, and it all blends together. Also, when there's varied dosing based upon symptoms, we tend to have poor adherence. And then, as I mentioned, schedule disruptions. Tim, I just want to pause there for a second and see any comments in the chat, any questions that are coming up for people.
Absolutely. Thank you, Dr. Walters. We did have one comment / question, which was around the use of Abilify. And the question was, isn't the use of Abilify and some other psychiatric medications closely correlated with diabetes? And so I know there's some research out there on the onset of type 2 diabetes for using some of these types of medications. Would you talk a little bit about that? Do some of these medications have a correlation to increased incidence, of type 2 diabetes? And what are you seeing in your work?
Yeah, so some of these agents definitely have an impact on weight, as we see. So some are better than others in terms of being weight neutral, but some of these medications really do increase weight gain. And so when people already have risk factors for diabetes, that can kind of push things over the edge, as well as causing those issues with insulin resistance. So somebody who's already struggling and then begins taking a medication that causes more issues with insulin resistance, we can see those increased rates occur. So looking for medications that can be more weight neutral or have less impact on the insulin resistance, and then also really working with those individuals, if we're not able to find other agents, on monitoring and lifestyle change ahead of time can help with that.
That's very helpful. Any other comments or thoughts about that from anybody in the audience?
And anyone else on the call, if you have other thoughts, please jump in. Always best to share.
I'll just add a comment as a psychiatrist that oftentimes these meds, which we start out as atypical antipsychotics, Abilify, Seroquel, Risperdal, they are often used for schizophrenia, but they're also used as mood stabilizers in bipolar. And then also they may be used for calming people down in a setting, if someone is psychotic or in a nursing home. And so if you have patients who have been admitted to the hospital, sometimes they may be discharged. They may have been started on Seroquel, quetiapine in the hospital, and it was a good agent while they were in the hospital and helped them be calmer, work through a delirium, sleep better. But when they come out and they still have Seroquel listed in their medication list, then you want to really explore, like, is that something that their doctors want them to stay on? Because like she said, if people already have diabetes, then it may increase their issues with it. And but that's one of the reasons we need to be careful of when we are prescribing. These are major serious medications, but hospital docs may be wanting to use them for short term. So just be sure when you're looking at the med list to see these type of medications. It's important because they can be factors to make things harder for the patient to do better.
Absolutely. Thank you so much, Patty. Any other comments from the group?
I was just going to add, for a long time earlier in my career, I did a lot of work with serious mental illness. And when we had these new medications such as Zyprexa introduced, we saw this increased education and information on the relevance of type 2 diabetes and the importance of us being aware of that and trying to help with education, behavior change. And so I think that has important. And I think that as we've seen, as Dr. Gibbons said, as we've seen these new lines of antipsychotics we've seen an increase. So
There's also another good comment in the chat by Melissa White that said patients can often be labeled as non-compliant, but in her experience, it's often because that we don't have time or take time to actually listen to why they aren't following their treatment plan. And I think that fits with some of what you're saying, Amy.
Absolutely. And that's that piece around adherence, is just recognizing that this really is going to be the norm, not the exception, and being able to use some motivational interviewing or other tools to take some time and just have those conversations, trying to look at those different barriers that might be coming up and how we can problem solve.
And what fits with that too is our language. A lot of physicians are still using the word non-compliant. It's kind of what we were trained on and grew up with, and that's a pretty stigmatizing word. And so, Amy, I noticed that you're talking about adherence, and you know, so that's and talking about that's more the norm. It's not that this is a bad person, a bad patient because they're not doing what they ought to do. We all struggle to do what we need to do, what we know is best. So I appreciate the language with saying it's not adherence. And yeah, Melissa says in her experience, the fastest way to alienate patients is to use that word non-compliant.
Right? It's very judgmental. And there's already so much guilt and shame that goes along with diabetes. So we don't want to add to that load. Sometimes too, I'll just talk about consistency. How are you doing with being consistent with things, and really acknowledging that this is hard, that this is a challenge. It's a big lift to have a condition that requires such a high degree of self-management. And so just normalizing that for patients and then helping them work through it.
We
All right,
had
so
more comment, Amy,
yeah.
and that comment was just often it could be related to the expense of treatment, and you touched on that, but I think that that's also an important piece of this. And as we're looking, and we talk a lot about social determinants of health, and so I think expense plays into this.
Absolutely. Yeah. Having that great contextual hat on as you're doing this, and being aware and thinking about those different areas and how we might be able to address it. So thinking about, so as a behavioral health provider, how can I support my patients with diabetes? Really kind of three main areas to think about. One is really helping, like you were saying, the problem solving and working on that motivation, supporting positive coping strategies and stress management, and then supporting that lifestyle change. One thing to think about with health behavior change is this awareness of kind of stages of change. This has become kind of common language now in a lot of training programs, which is great. But I always like to just mention Prochaska and DiClemente and the various stages of change, and recognizing that when you walk into a room, often as a provider, we are in this place of ready for action and we're ready to problem solve, but patients might not be there yet. And when we look at the literature on health behavior change, the vast majority of people are actually in this state of contemplation, 70 to 80%. So recognizing that we may need to have a conversation about this and help move them from that place of just thinking about it to planning and action. And that's where motivational interviewing can be fantastic. Hopefully everybody on the call is familiar with motivational interviewing. If not, it's something that's definitely worth investigating and getting some training on. So Bill Miller and Steve Rolnick are our authors that we credit here. This is just a patient-centered approach that's really helpful in working on following patient's agenda, following patient desires, and really building motivation for positive change. It uses a guiding style where we're encouraging the individual to solve their own problems based upon their goals, based upon their experience, based upon their values. And as we're working in this relationship with this patient, we want to be kind of dancing side by side and following with them, as opposed to wrestling and feeling like we're trying to get them to do this and then they're pushing back and we're going back and forth. So we're using a guiding style as opposed to a directing style, and doing more of this consulting approach as opposed to instructing. Motivational interviewing uses a lot of active listening, so kind of person-centered counseling skills, as well as open-ended questions where we're exploring concerns, exploring their ideas, and really affirming and acknowledging the positive steps the individual's taken to date. So having this style in our approach is really helpful in building motivation. Also focusing on values. There's been a lot of research and a lot more focus on the importance of values with health behavior change. So looking at, what is it that this person wants? What do they need? What are the different supports we can help them access? Are there ways that we can create accommodations that might be helpful in achieving those things? And then focusing on, what would be some next steps that we can take based on what's important to them and their values. Couple of comments here on stress. Stress becomes a really important variable to focus on for our patients with diabetes. We know that when people are under stress, we can see increases in glucose levels because of the rise in stress hormones like cortisol. So helping them recognize and develop some strategies for managing stress. I like to talk to patients about stress just in terms of, what is stress? It's really when the demands of the situation exceed our ability and resources to cope. And lots of different things can fall into that. We know that there are physical, there's a huge physical impact to stress, and then a large number of primary care visits. Sometimes we see up to 75% are related to kind of that physical impact of stress. Impacts lots of different health systems. So just having an awareness and talking with patients about this and ways to kind of cope effectively. One of the things we see is that oftentimes our patients will fall into unhealthy patterns to cope with stress. I like to talk about, it's human nature to avoid things that are painful or uncomfortable and to do what's easy. And so oftentimes this is kind of that unhealthy habit of, I've had a really long day, and so I'm going to go crack a beer, or I'm going to go have some chocolate, or I'm going to sit on the couch and watch Netflix. So helping patients to develop some healthier ways to cope with stress and handle that effectively. Sometimes we'll just kind of brainstorm some different ideas and then identify, what would be 3 go-to strategies you could do before we turn to the chocolate, before we use some of our substances or other things. It doesn't have to be fancy. It can just be kind of a basic way of brainstorming and coming up with some alternative strategies. We have some handouts in our office too about what are some healthy ways to deal with stress, and just giving people kind of a list as a starting place. Oftentimes they can generate additional ideas. I know many of the BHCs are well versed in ways to manage stress, but just something to kind of touch on and think about. And then we want to really focus on supporting this behavior change. So when we're entering the visit, talking a little bit about, kind of what's the concern, why does it create a problem for the individual, coming up with a plan of some things that we can do next, and then how do we want to do that? I like this kind of 4 Qs of case conceptualization because it helps us in our brief visits to stay focused and identify some things that we can really address. Thinking about understanding kind of the basic nature of the behavior, I like to follow using contextual interviewing out of the PCBH model, where we're looking at those 3 T's. What's the time, trigger, trajectory for the issue? What need does it serve? And is it helping them achieve their goals and align with their values? Or are we getting into, is it creating outcomes that are counter to that? I like to use this graphic with patients when we're talking about behavior change. What people tend to expect is that they're going to kind of start here and make this lovely upward forward progress with one positive step after the other. And that's just not what happens. Instead, what we see when we look at actual change processes, people kind of start going and they do pretty well, and then something happens and it crashes and they get off track again. And then they start doing well again, and then something happens and they get off track. So helping them recognize that this is normal, and we can talk about, okay, when we were here and things were doing really well, what were those behaviors? What did that look like, and how are you doing? And then what are the triggers that create this fall, and how can we avoid those or be proactive to kind of how to extend those periods that we're on top and reduce those times when we fall down? But recognizing that if we do have a decline, there are things that we can do that they've been successful in before and getting back on track. We talked about adherence, and I think one of our roles can be to really help improve that adherence. So as Patty was saying, taking that time and having those conversations, using that great contextual interview as a way to help understand what some of those factors might be that are contributing. We can use functional assessment to try to identify what some of those barriers are, whether it's an internal barrier or an external barrier. And some of the common ones that we do see are things like finances, sometimes transportation issues, getting to appointments, so some of those social determinants of health. Sometimes patients just don't understand instructions. We had one individual who was on an insulin pen and was just continuing to struggle with her glucose levels and was, just saying, I'm taking this regularly. The husband was there at the visit and he was acknowledging. One of our educators was able to just say, can you demonstrate for me how you use your pen? And she was actually injecting with the cap on. So she was trying to do that. And then the insulin wasn't ever making contact with the skin. So just things like that, we can help kind of troubleshoot and problem solve. Avoidance also tends to be a common factor that gets in the way. So helping people kind of re-engage. And then sometimes just that negative reinforcement. It's something they don't want to deal with, so they fall into these negative reinforcement patterns. So asking questions about and looking at what might be the function of that behavior, and then how can we troubleshoot some ways to kind of overcome that. Definitely the physical barriers, we just want to problem solve those and connect people with resources. And then if they're internal barriers, being able to use MI or some of our ACT and FACT strategies to help connect with values and enhance motivation can be helpful. Most of you have probably seen this before, but I always like to kind of touch on contextual interview. It's a great way to just assess those different areas that may be affecting diabetes management. And, thinking about the problem and how that interacts with these work, love, play, health. And this definitely comes out of Robinson and Strassel, and Beachy and Bauman have done a lot of work in this area, talking about contextual interview and having a basic understanding of it. So we can conceptualize our challenges to diabetes this way as well. Thinking about using functional assessment, this comes out of behavioral psychology, identifying what some of those basic elements are that are driving and maintaining that behavior pattern. And I like to break this down looking at some of the different thoughts, feelings, behaviors, and environmental factors that may be impacting that dynamic. Thinking about what might be some of the triggers, as well as some of the sustaining elements, and what we could do to help kind of change this process. I'll often use this graphic and talk about the behavior pyramid, looking at these 4 different levels and how they may be impacting the individual. And then we can actually just talk through that and start to identify together, what are some of the thoughts that they're having around this challenge that they're having with their diabetes? What are some of the feelings that are coming up that might be getting in the way? What are some of the behavioral patterns that they're falling into? And then thinking again, always about that context and environmentally what's going on and how might that be contributing or getting in the way. I'll often do education with patients just about that thought, feeling, behavior relationship so that they can start to see how, oftentimes we're focused on the actions, but if we go back upstream and look at what are the thoughts that they're having, what are the feelings that this drives, and then what are their actions, and then what's the consequence? And is this something that's supporting their values and health behavior goals, or is this something that might be getting in the way? I can see that there's also some chat there. Wanted to pause for a moment. Kim, any comments there that we want to address?
Absolutely. So we do have a couple of comments. The first one, Dr. Walters, is, do you have any advice for patients with significant food aversions as related to primary care behavioral health management visits? So if someone's coming in to a visit with you and they have some significant food aversions, any thoughts or comments?
Well, yeah, that's a big area in and of itself. I think first of all, just starting, with some motivational interviewing to understand a little bit more about those aversions, what's driving them, what that might be. Sometimes we can use some shaping behaviors. Oftentimes, one of the barriers that I see in this setting is people struggle with produce intake, and that's one of the things that we're always trying to increase. So creating opportunities to explore, different types of fruits and vegetables, adding them slowly to different meals. We have dietary support here at the Diabetes Center, and I think that that's one of the things. Some of the primary care offices do have dietitians that work there, or at least that they can refer to, and that can be another really helpful way to support that, is just making sure you're pulling in that dietitian, getting some additional expertise and support that way.
Thank you so much.
Other comments in the chat?
Absolutely. The other comment we have was, thank you for sharing. It says, I had a patient last week say that he felt bad about himself, so he was intentionally sabotaging his diabetic control. Now his A1C was 10.3. Do you see that? Do you hear that patients are coming in saying, I'm feeling bad and I just gave up. I gave up the plan that we've been working on. And any thoughts?
Absolutely. Yeah, such a common phenomenon. And there's a lot of burnout that goes with diabetes, and there's a whole other literature around that. So kind of acknowledging that that's a common phenomenon, trying to talk with the individual about, let's look at what happened and what were some of the triggers that might have contributed to that. Trying to reconnect with values, what's important to them, and then kind of gradually getting back into that pattern, starting with a couple of small behaviors. So maybe we start working on if self-monitoring was one of the things that got in the way, can we gradually start building that back into the day? Do we need to increase social supports? Sometimes bringing family members in, or problem solving some of the other challenges that are going along with that. And then definitely, if people are starting to slide into that place of feeling more depressed, addressing the depression head on can also help really improve adherence. Other comments or thoughts?
And I also want to take a moment and invite you to come off mute if you'd like to ask Dr. Walters a question, or if you'd like to comment further.
Hey, Amy, Nick Navarro, quick question for you.
Yeah.
So, I always kind of go back to sleep as well, in terms of any types of efforts to do behavior changes, have the motivation to, even the working memory piece of like remembering what my doc said about, needing to make this change or that change and what impact it would have. Do you see an impact of, educating patients on sleep hygiene as they're kind of working towards these big behavior changes? Because even that in and of itself is a big behavior change for people, changing their sleep habits.
Absolutely. And I'm so glad that you brought that up, Nick. You're exactly right. Thinking about health overall, and sleep is one of the areas that we always assess in our interviews, because not getting enough sleep, causes a stress response within the body, and that can definitely lead to variations in glucose levels. So just talking to patients about overall health and ways to improve that. And I absolutely love the idea of focusing on sleep hygiene, and we do that on a regular basis. So thank you for calling that out.
Thanks, Amy.
And Amy, I wanted to comment a little bit more on that patient that, literally he's around my age, not overweight, but a big genetic component with his type 2 diabetes. And he said, I hurt myself because I feel bad. I intentionally sabotage my diabetic control. And one of his big issues was he does not sleep. And so he asked me for info on foods that would help him sleep because he didn't want to take medicines. But interestingly, which I've not seen this, I don't know if you have, he has problems where he forgets to eat. Like literally, I asked him what his food intake was, and he's like, maybe once a day. I'll have pineapple and cottage cheese. I'm just not hungry. And so that was kind of a new thing for me, and I wasn't quite sure how to address that.
Yeah, it sounds like he's struggling in a lot of different areas, and you bring up such a great point. I'd love to just piggyback on that for a minute. So one of the things that can also, especially in our patients who take insulin, if they are not following a consistent eating schedule, and if they're going long periods without food, then the liver is a secondary source of glycogen, and that's going to dump some additional glucose into the bloodstream to kind of keep them going. So if they need insulin in order to counteract that, and they're not taking any insulin because they haven't eaten anything, we can actually see a rise in blood sugars just from not eating as well because of that secondary function. So sometimes doing some education around that and helping patients understand that they're going to have more consistency. They're going to have better, consistency in glucose levels if they're able to eat meals regularly and dose accordingly. But it sounds like this individual has a number of different areas that you could work on when it comes to focusing on trying to improve that sleep hygiene, trying to improve consistency with meals, and then just doing a little bit of exploring about kind of some of this self-sabotage, building some other ways to feel better about himself. Because you're right, diabetes can be one way of kind of indirect self-harm. And I think there's a difference between that versus the patients who are just kind of forgetting and are non-adherent that way. So teasing that out a little bit and then being able to address that clinically. But thank you for sharing that, Sarah.
Or excuse me, Dr. Walters, we have another question. It is, the concept of reward meals comes up often. What are your thoughts on the benefits or the pros and the cons of this occurrence with reward meals?
Yeah, it's kind of an emotionally loaded topic, isn't it? So, ideally, we want to try to take some of the emotion out of food and not make food our primary source of reward. I think it creates just some real negative dynamics around that, and helping patients identify, what are some other ways that you can reward yourself that don't involve food? So that's oftentimes a starting place for me. That said, if we get, I like to talk about kind of moderation with diabetes, and getting too extreme one way or the other. Also having like, this is a good food, this is a bad food, just creates things to be more emotionally loaded. So instead, trying to think about moderation, try to think about healthy ways to incorporate different foods, that we don't want to have any foods that are 100% off limits, but instead just trying to use portion control, and also thinking about balancing that. So for example, maybe somebody really wants to have cake with their dinner. Can we talk about what's a serving size of cake and what's a reasonable amount? Would there be some other ways that we could reduce the other carbohydrate intake with the meal? And then if they're on insulin, can we talk about how to appropriately dose for that based on what they're eating? So, all foods are okay, trying to, kind of destigmatize some of these things, getting out of some of those dynamics around good foods versus bad foods, and then finding alternative ways to create rewards so that we're not always in this cycle of using food as our primary source of reward. A few ideas on that.
Hey, Dr. Walters, it's Melissa White. I could say a million things, and I think this is all wonderful conversation, because for anyone who deals directly in patients with the management of diabetes, the first thing I want to say is, when diabetes gets complicated to manage from a provider's perspective, primary care sends them to endo. I think we all, as part of the healthcare team, need to remember that once it got complicated, they got moved to someone else. That needs to all remind us that it's complicated. And when we're explaining how to self-manage diabetes or any chronic condition, we need to take a step back and remember it's complicated for the provider. So we need to remember all the convoluted aspects of it from the patient's perspective, because it is complicated for patients to manage. But the one thing I struggle with the most is getting over that barrier where insulin is a punishment, where providers still say, well, if you don't you're going to go on insulin. And oh, that's so frustrating, because insulin is not a monster. I usually start with, well, your body makes insulin naturally, so try to go backwards and recreate that trust relationship where it's not a punishment. And often patients spend less money and feel so much better if they even just go on one long-term insulin injection a day, because they can cut off all those other medicines that are expensive, and they get better control and they feel better.
I'm so glad that you brought that up, Melissa. You're exactly right. And oftentimes, people have they don't understand that diabetes is progressive in nature. So sometimes, even though they're taking care of themselves and doing the things they need to do, they may need insulin in the end because of that overproduction that happens. So thinking about insulin as just one more tool and something that actually might be able to give them better control and help with their ability to feel successful in managing their condition. So you're exactly right. We don't want to set this up as a punishment or a monster. It's one more tool in the toolkit that can help them get better control. I really appreciate all the great comments and conversation around this. I want to get to just a couple more slides in our last few minutes here so that we can just give you an example of kind of how to use these ABCE elements. So just have an example intervention to talk about here. So Mr. V has an A1C of 11, needs help with lifestyle change. The context is he's a 60-year-old male, has a wife who's this great cook, high stress job, really worried about retirement and money. Multiple health issues like hypertension, neuropathy, insomnia. Used to enjoy outdoor recreation, but neuropathy has now gotten in the way. He's had diabetes for 15 years, used to be pretty active, and this A1C is just creeping up. So thinking about using these ABCE elements and thinking about the functional impact of the behavior, we can break this down and looking at, so from an affective standpoint, he's got pain, he's got fatigue, he's got stress, he's discouraged. Cognitively, there's some of these beliefs like food is love, my wife's going to be insulted, I can't do what I enjoy anymore, so what's the point? Behaviorally, he's using food to cope with stress. Food is the source of pleasure and connection to his wife, and he's avoiding activity due to pain. And then when we think about kind of that contextual piece in the environment, he's got this high stress environment that's food rich with limitations in activity. So a couple of intervention ideas as a BHC would be, number one, we can work with him on increasing his activity. This is going to give us a lot of bang for our buck. It's going to help reduce glucose, stress, sleep, obesity, fatigue, a lot of these factors. We can help him find other forms of physical activity, and remember that, starting small to ensure success, working on recreation, kind of adapting some things, having a family meeting to discuss healthy ways and food choices, looking at changing the environment. Sometimes this is the low-hanging fruit and an easy place to intervene. So high temptation foods, removing those, trying to make activity part of the regular routine, and really prioritizing health. Sleep hygiene is there, and that was one of the things that Nick brought up, working on stress management, or we could do some cognitive work around kind of beliefs about food and behavioral engagement. Finally, just some important concepts for intervention, thinking about, where's that motivation? Can we help patients in using motivational interviewing? What are their expectations and beliefs around diabetes? What are the social supports that are there? What are the behavioral strategies? And so on. And so I really appreciated today's opportunity, such a lively discussion. Probably have just a couple more minutes for questions, and then I know everybody needs to transition to their clinical care.
Do we have any burning last minute questions for Dr. Walters?
Hey, me real quick, Nick Navarro, I do want to say thank you very much for the information. It's always great to hear you speak on this stuff. One quick comment, one quick question. So on the behavioral change front, I know in CBT, we tend to use that whole behavioral activation kind of thing, right? And one thing that could be helpful is when you're trying to get a patient who's maybe less active to pick up some new activities, is to do sort of an assessment of activities that they used to enjoy, and to help them to sort of assess which ones provide a sense of mastery, which ones provide a sense of enjoyment, and then to kind of just slowly work that into the daily schedule so that we're working with stuff that they have already that have already been rewarding in some way in the past. But I really loved your slide on the reality of behavior change being an up-down sort of a thing. And I think what I tend to see in the behavioral health world is that when they get to that low point in the behavior change where they've kind of fallen off track, that's when, especially if there's depression or anxiety, there can be this disengagement from services completely for a period of time. And I'm just wondering what you tend to do when things are going great, and then there's a little bit of a fallback, and then they plunge down, and then maybe want to disengage completely.
Yeah, really trying to go back to those values and using some motivational interviewing, talking about what life was like when they were more engaged, recognizing, kind of what's most important to them, and what's the impact that it's having. So for example, maybe it's family, maybe it's maintaining that active lifestyle, but using a lot of motivational interviewing in that area. And then I totally agree with what you said, Nick, really revisiting back to, what was it that was working well before, and what was that like for them? So lots of different opportunities to use that different behavioral activation, working on some CBT, doing some motivational interviewing. Those tend to be the strategies that I fall back on.
Thanks, Amy. Yeah,
absolutely.
All right. We know that it is 8:59. We want to thank you again, Dr. Walters. This has been fantastic. One of the things that we often hear is when people are coming into primary care, we heard it from several people today, diabetes is one of these issues that's really difficult to manage. However, it's coming to primary care. And so whether it's primary care providers, care coordinators, behavioral health consultants, case managers. It's affecting the whole team. And so team care is critical with this. We really appreciate you zooming into Arkansas from Idaho this early and really sharing some of your experience. It's phenomenal. And we would love to have you back at some point.
Thank you so much. It was great to be here today and really appreciate all the participation and the invitation. So I hope everybody has a great day.
Thank you.
You bet. Bye-bye.
Bye-bye.